So, good afternoon, Dr. O, and thank you so much for coming back to see us. This is the third session that we recorded together. Now, maybe the viewer's very first session. So, with that in mind, do you mind just sharing just a little bit about your background with our viewers?
Hi, everyone. I'm Dr. Olena Berezovska. I live in Canada, in Toronto area, and I've been in Canada almost for 30 years, but I was born in Ukraine, in West region, and by
Indeed.
yes, and by education, I'm a physician, and by specialization, obstetrician gynecologist. So I moved to Canada with family in 1996, at the end of that year. And I passed exams to be qualified as a doctor, but spent almost like 20 years in Mount Sinai Hospital as a research physician in research area, clinical research, because this has happened, and I like research, by the way. And also I was doing like lecturing and participating in continuing medical education courses, like, helping with organizing and of these events, and etc., etc. But I actually started to write books because first I was creating a blog, mostly for people from post-Soviet republics, because what I realized, the medicine there is on a very low level and quite corrupt, and plus very old, and the progress there is on a very low level. So that's why I decided to help people to be some kind of bridge between modern progressive medicine from North America and including Canada, and then share this information. I did it for free, but the question was there were so many questions about especially women's health, that I decided, okay, instead of repeating answers, I started writing books. And the books were accepted very nice. So I got some offer from publishing houses over there. And then I became known, let's say famous. And I was on TV, on radio, and I was lecturing in medical schools and universities, so in Ukraine, and even in my alma mater, which is for me an honor to be and to give lectures. And so this is what I was doing for the last, let's say, almost 10 years. But the war in Ukraine actually damaged a lot, like a lot of plans and plans for future. So I started supporting my Ukrainian people in helping them, and I stopped working with Russia, but I'm still providing a lot of information, and it's very valid and serious and necessary information, how to survive in this extreme situation, how to be pregnant, how to carry pregnancy in extreme situation, and a lot of kind of like material I provide to Ukrainian people. And this is who I am. But also I was interested in psychology. That's why during COVID and the last year also, I took a couple courses, some of them from University of Pennsylvania on positive psychology. And
Which is, I'd like to highlight the gold standard for us in positive psychology, because that's the home of Dr. Seligman,
yes,
Martin Seligman, who founded the field, essentially.
and I'm very kind of happy that one of my, not colleagues, she's psychologist, let's say, but I know her personally, and she created with Dr. Seligman and other famous psychologists in the world entire course, positive psychology for Ukrainians. And actually it was online course, and it was lasting for 12 weeks. And
Okay.
just like, with lectures of all known psychologists from around the world, who Dr. Seligman was lucky, or let's say he was kind to bring as a team. And that's why for me it was like, a signal that probably I need also to bring some other psychologists from positive this international association of positive psychology, and we need to speak to people. And that's why I started to do the podcast.
Wonderful.
Yeah. So this is short, but again, it's a lot to say. And as I said in our private conversation, I'm not ready to write autobiography just all about myself.
You're busy letting it write itself.
Yeah, I didn't want to waste time. When I'm retired, I don't know when I'm retired, then I'll start collecting all data and bringing in one book, maybe. If
Well,
somebody
thank you
would
so
be
much
interested.
for sharing your time with you, because you are a very busy woman and you're very active in the International Positive Psychology Association. So we really appreciate it. And we have a small group of young women who have gathered their questions for you. And as we spoke right beforehand, before we began recording this session, you've done your research because you are a research scientist and you are ready for the questions. So I'm going to pass the baton. Start with it as you will. Thank you.
Thank you. And I prefer true information because I'm responsible for sharing this information. That's why whenever I have questions or whenever I have the theme to discuss, of course, I do my research just to provide the best what I can. And I know the first question we got, not the first, but I mean the first for this session, it was about Pap Smear and when to start.
Right. Do you mind if I read it?
Yes, please. Yes.
Right. So how important is it for 18 to 25-year-olds to get a Pap test? Do they still need to undergo a Pap test if they've not been sexually active?
That's a wonderful question because it caused a lot of dilemmas between doctors and also between like patients or women, let's say. Before there was a kind of recommendation that every young woman that started the sexual activity, and it means like, you know, through vagina, not other type of activity, has to be tested and through this Pap Smear. Because what is Pap Smear? Let me explain in a couple of words. So Pap Smear, it's actually short, this like short name for Papa Nicolaou's test or Papa Nicolaou's smear. And Dr. Papa Nicolaou, it was Gregorius Papa Nicolaou. He was a Greek physician that in 1920s created this test because he was pathologist also. He liked to look through the microscope on cells. So he was collecting a lot of tissues, a lot of like, you know, and then he used his wife as a guinea pig to collect vaginal discharge and actually look through the microscope. And in this way, he found like different changes in cells and described it. And he moved actually to United States and there was like exploring more, but it took almost 50 years when it came to kind of normal classification, because at that time we hardly knew about cervical cancer, especially Italian. And it took 50 years, and then actually we found that through the cells, through the changes in cells, we can say if we have some precancer condition or cancer condition. And it was the base for any other cytological test, like we say, because it's cytology, it means learning the cells. And through the classification of cells, we can say what kind of changes, good one or bad one. And the first country that started to screen women on cervical cancer was Australia. And approximately in 70s, I guess, I don't remember exact date, but on 70s, Australia created the entire government program or state program to test every woman in Australia and look for these changes. And that's why they start calling it Pap Smear, because it was a smear. So they actually open and special, like, you know, by special instruments, the cervix, and take from the surface of the cervix, and later they start digging deeper, they start taking from this channel cells, like discharge actually, and looking through the microscope. Of course, it was colored by special paint, and then it was like studied. But it took another, like, you know, 50 years, approximately 50 years, when every country in the world started doing this. But again, it was the old version of Pap Smear. And recently, we start doing a new version, and I know it's, but again, in many offices, you still have this old version, like, you know, when the discharge is dried and then colored, and then they look like, you know, the pathologist looking through microscope and describes. But also we have a new version. It's called liquid cytology, or sometimes they called it Sure Plan, BP Sure Plan, whatever. There are different companies that create this. When we have this discharge, we use, first of all, different instruments. We use like cytobrush, we call it, or cytobrush, and we don't damage the cervix so much. Then we put in a special liquid, and then everything on the brush goes down on the bottom, right? And then they use it, so it's much better than just like the old way, because we could miss something on like, you know,
which is still used in parts of the world, you'd say.
Yes. Depends on the country, depends actually on the equipment, and depends how progressive the doctor is, let's say this way, because it's actually already like this liquid cytology, at least for 10 years, that they widely use in North America and Europe. And then another one new direction, and they start to use this state programs, like screening programs, like we say, for cancer. It's actually computerized, and it's much better because when you look like with your eyes, of course, you can be tired, you can miss a cell, you can, like, you know, the computer looks not just like counting every cell, but the computer can look through different in different directions, like, you know, and use filters. So can look much better, and they use a couple of filters which our eye cannot use. That's why we have new technology. But coming back to Pap Smear, what gives us, like, you know, the Pap Smear? So before there was no classification, very good classification. Everybody could describe whatever they see in different way, and that's why we could miss a lot of bad things. But the Bethesda system was created like approximately 50 years ago, and its classification of these changes in cells. And we had a new, and then it's actually improving through the time. And we had the new edition in 2013, I guess. After that, I don't remember if we ever had. But so now we have 5 classes, like we call. It's not that, like, we never call it classes, but let's say try to explain 5 description, the main description.
So 5 different categories.
Yes, categories. Yeah, let's say, because before we had classes, before we had grades. Now it's a little bit, it's simplified, that doctors wouldn't do any mistakes, that kind of more like simple to understand what's going on. And the first category, it's actually when you get, it says negative for precancer and cancer condition, or intraepithelial lesions, like we say in medical terms. So when you get like negative, it means, okay, you're fine. Even if there is some changes on the cervix, but it's fine. It's wonderful, wonderful result, you know, so you shouldn't even bother yourself and do something, right? Then another one, it's, we found this like ASCOS, it means atypical cells of unknown significance, like, you know. So it's, again, it's not precancer. It just could be changes. It could be inflammation, could be repair, it could be anything, like could be infection. That's why sometimes you might be required to repeat the test in a couple months, you know. Then actually we have the intraepithelial lesion, low grade. And before, many years ago, it was treated as precancer. Now it's not a precancer. And you can find in many young women, especially when also they're infected by HPV, like human papillomavirus, right? So it's not so bad, again, it's not precancer. And only high grade of intraepithelial lesions, we call it, like in an old classification, we call it like severe dysplasia, or like, you know, this like high grade dysplasia. Now we don't use word dysplasia, but it means this could be pre-cancer. And then the last class, of course, we have cancer, and it could be like, you know, cancer in situ and cancer. And for each category, there's a very clear description of cells. So it means the doctor who's looking through this, or the computer knows itself, but the doctor who's looking through the cells, that he has to describe precisely what he sees to avoid any kind of like, you know, mismatch or whatever, like, you know, starting like anyway, like wrong description, let's say this way. So that's why it's, but we call it screen. Why we don't call it diagnostic test? Now I would say we might call it diagnostic test because computerized system, when actually the level of mistakes is very low. We can say that it's hardly a mistake, but when we used our eyes before, so then we use this subjective factor, whatever person sees. That's why to confirm the diagnosis, we had to do a biopsy. We had to take a piece of tissue and then go in very, like, you know, deep into the structure of this tissue and then confirm that there are changes or there is no changes, especially when it comes about pre-cancer or cancer condition, right? That's why we call screening. And again, it's much easier to do, like to screen everyone. When about diagnostic methods, we talk when we suspect it and we need to confirm or disapprove, right? So this is how it works. Regarding the age, as I told before, it was recommended that whenever you start like sexual relationship, then you have to be tested.
Which is a part of this question, a second part.
Yes. So, but actually it's changed in a way that what we have, of course, everything based on clinical research. We're not talking like from nowhere, like we do not kind of create our own suggestions. And in a couple organizations are involved in creating the recommendation, and it's like some professional medical organizations, some state organization like this Committee of Control Disease, right? It might be like National Cancer Institute, it's semi-private organization. So everybody tries to be on top of everything. So that's why we have a little kind of discrepancy in recommendations. But again, you have to confirm why you do this way. So in general, we have some consensus. So now we recommend to test women when they achieve 21 years of age. Why 21? Why not like, you know, sooner or whenever they start the sexual relationship? Because according to statistics, the cervical cancer, and we're talking mostly about epithelial cervical, because different types, we have like different types of cervical cancer, but the most common it's related to is epithelium. It's like, you know, if you remember something from biology, so this is what it covers us. It's like skin, and it's you know, everything inside. But anyway, when it's when we're talking about why 21 and not like, you know, older. So the cervical cancer is a very rare disease, even if we hear a lot. But why we hear a lot? Because it's the only program that is implemented so well about the screening. And another second one is the breast cancer. Okay. But we have 9 actually screening programs, like cancer program is like colon cancer, it's prostate cancer, it's lung cancer. I can add some melanoma, like skin cancer. I mean, we have 9, mostly 9 cancers, not in every state of the United States, no, not even in Canada, not in every province, but in general, 9 states. It means controlled by government and sponsored by government, because here we have some program how to find these cases of early stage of cancers and treat on time and save person's life, right? And that's why it's supported by government, and that's why we have the state screening programs. But the most successful, actually, it's like cervical cancer. The most successful, why? Because it's easy to do. So you take the vaginal discharge and then you look, and that's it. When we talk about other, like even like another one I didn't mention, it's ovary cancer screening program. It failed in many ways, and everybody now is kind of discussing what we're gonna do next, because we usually see ovarian cancer when it's too late. So, but the program failed. But when we talk about lung cancer, whatever, it's related to some invasive procedures or kind of like X-ray, let's say lung cancer, or colonoscopy. Even now they improve, because now they used to look for blood in your stool, which is much easier than to do colonoscopy, right? But we improving with years in the screening programs. But cervical cancer and breast cancer probably is the most developed, where tons of money is involved, right? But it works. Even like when we talk about breast cancer, there are some changes, because now we don't do mammography every year, but still a lot of confusion. But I mean, we have some changes. When cervical cancer, we have changes only in a quality and high level, like, of equipment and this technology we use. But the procedure is the same. We start from Pap Smear. But again, we have changes. Now even in the United States, we have recommendation to start not from Pap Smear, but start from looking for human papillomavirus.
Right.
Because 80, even 90% of epithelial cancers are related to human papillomavirus infection. And because it's confirmed by many clinical research. So it means if you had a contact with HPV, it means you have higher chance to get cancer than you never had. But this interesting moment that even if you had, because we know approximately 60 young women between 20, 30 years, even a little bit younger, are infected, had a contact. But our body, our organisms actually fighting the infection, and then up to 90% of women who ever had contact with HPV, approximately in 6 months, but usually we say in a year, we give them more time, they will be cleared of virus.
So it's
we never
effective.
Any kind of confirmation that they were infected, which is good. It means our body knows how to clear off this virus.
That is good.
We don't know if it's cleared or the virus stays somewhere in neurons or whatever. We have no idea, because it means it's on such level that our new methods cannot detect the virus. But it's okay. We cannot detect. It's okay. And that's why they say that maybe we should know who's infected, who is not, because who's infected probably needs kind of more visits to a doctor to have this. And to have this Pap Smears or whatever, because if you're not infected, well, it's kind of very low chance that you will have some changes, like we call histological changes related to HPV infection, especially this precancer condition. That's why, they say maybe you should start not from Pap Smear, but start from HPV testing, and they change this recommendation now. But again, it could be done both, because there is co-testing. Also, it's started in
often.
So you could hear
at least in
everywhere.
the United States,
We do co-test, and we do Pap Smear, and we do HPV test, which is okay. I mean, it's normal. And then again, if we got the normal results of Pap Smear, it means even if the virus is present, it means we can repeat in 1 year. It means it's still not damaged, and we cannot treat this infection. There is no medication, no methods to treat infection. We just follow the woman, and we ask her to come and take the test again in 1 year, usually. If we see some changes, like simple ones, some kind of little changes, but not pre-cancer, we can say we can retest in 1 year or 6 months. But if we have more serious, in 3 months, let's say, because we know then almost in 60%, even pre-cancer condition in young women, 60% of young women will disappear, or how we say will be self-treated, which is good. So there's no push. Then another one serious moment, that the cancer, to develop the cancer takes time. So we found the peak of like cancer cases, usually after 40, 45, usually 46 till 51. And it's a huge difference. We know that it takes 15, 20 years to develop the epithelial cancer. I'm not talking about the other cancers, but only this time. So it means why we should press and push these young women, push them into the stressful situation.
Right.
Because we say, oh, you know that cancer can be developed. Yeah, but it takes time. So we still have time to check the condition of the cervix. And what is interesting, usually when women achieve like 35 years, 40, they hardly visit the doctor because they're wise, they're not afraid. So they kind of like, they have wisdom of life, let's say this way, till that age. And they're not so afraid of cancer, even if they're afraid, but they're busy with children, they're busy with business, they're busy. They have like, okay. And they actually healthy most, because usually they're very healthy, the healthy population. And that's why now many doctors said, maybe we have to change recommendation. Maybe we should push women from 35, like around, like even like 30, let's say, but maybe like older women, like 35, we have to push like for 1 year checkup, not like, because now we have checkup every 3-5 years. If the good every 3-5 years. So if the girl, as a young woman goes in 20 and checked and then everything is fine, we say come at 3-5 years. Okay, it's up to you. But then we say, okay, but because we start seeing these cases more often after 35, close to 40, maybe we should pay more attention.
That makes a lot of sense.
Category. Yes. So we start kind of losing logic and using the data we have, and probably we will have some changes in the
That is very interesting. So this individual who wrote this is going to be somebody's 18 to 25, because this is the demographic that we're working with.
Yes.
But while the question now, from what I understand, and please do correct me if I misinterpret it, is maybe get a Pap test if you're not sexually active. Definitely get a Pap test if you are sexually active because of the HPV virus.
Yes, but Pap test doesn't show virus, so the virus is different test.
That's right. That's right.
So it means visit your doctor and do test. And it's better to start from HPV if you're sexually active. And also they can offer another test like for diseases, sexual transmitted diseases, see, because sometimes the women, they don't know.
But if one's not sexually active,
if they never had any sex, like, in vagina, then they probably will not be tested for Pap smear, but they might be tested for HPV in some way, but again, we don't know what to do with young women, even teenagers who has HPV, because we don't know how the HPV appeared there, because we have approximately 13-15% infected with HPV, and they never had any sex. And it's not about do not trust young generation. No. It's just like we don't know how because we found that they could be somehow infected. And again, HPV, there are like 135 types, even more, 140 something. Every year we get in more types. And only a few can affect urogenital area, right? So whatever you have papillomas here, like, and you don't like, it's also HPV, but it's not it's harmless in some way. It's not related to cancer. But there we have only few one that related to cancer. But also it's related to cancer of rectum, and we know this, and also in men, homosexual men, we have now increase of cases with this throat cancer, like laryngitis, larynx cancer, right? But I mean, the virus can affect many areas, but when we talk about women, and mostly we're talking about this traditional sex life. And what also we have, why we said about 21 now, not sooner, because statistics show that young generation become wiser, and women actually get involved in sexual relation in older age. So before it was like 14, 13 sometimes. Again, it depends on demographic area, right? So it depends on the N+ family and other things. But we look through like average statistic data, right? and the age is increasing because they have education, they have sexual education,
right.
they have more information, they have teenagers groups like I'm a gal or whatever, so they know more and they're more cautious now, and they start using this preservatives because it's cheaper, and then they know about the sexual diseases. So
Mhm.
women became more cautious, and they start like we had like a couple years ago, the middle age of first intercourse was 19 years, which is wow, right? And then probably now, probably a little bit higher. But it doesn't mean that they don't have sexual activity, because they can use oral sex and anal sex and
Mhm.
many other type of sexual activity, right?
Mhm.
And again, when we talk about anal sex, they have to be protected because it can increase the risk of sexual transmitted diseases, and also the risk
Right.
of cancer, because the virus can be passed through anal sex as well, and then through oral sex as well. That's why you have to be like very careful when you like try and want to start the sexual life, and not just
Mhm.
jump into the first kind of hugs of men, and then you know what I mean. So but that's why we start saying that probably the age 21, and is another question about the age of majority, like, you know. So before, it's always a confusion for doctors. Should mother or father, of course father, come on, but mother be presented during the checkup?
Mhm.
Okay. And even if United States, you find it like if we do the clinical studies, we usually say the woman should be 18 years older. In some, I know some countries might be like 17 years older, but usually 18 years old. But again, it's very shaky population. And some lawyers and other kind of like people, they say, no, it has to be 21 when they
Okay.
have make full decision, right?
In some countries,
Uh,
okay.
yes, but I want to come to kind of this conclusion that actually is the decision of every woman when to start. So if there is any kind of fear, and let's say the woman is like not 21 but 20 or 19 or 18, or she started to have this sexual relationship, and if there is any fear, just go and check yourself, like, I mean, go to the doctor. Nothing wrong about this. And it's necessary to go to a gynecologist, because usually a family physician can do this very easy. I go myself to family physician when I need all this checkups, you know, and that's normal. So go to your family physician or general practitioner. It's simple test. What they try to do now, they want to create the test like home test, and they started to create a home test or during COVID infection.
That's
But
wonderful.
yes, so they can go to the washroom and do the test instruction, how to do it, like, you know, but still it's experimental. We don't have
Mhm.
valid data if it gives us like valid information about the condition of the cells, if it's properly taken, you know. And why I'm saying why we creating home tests, because I remember before we were taking some instrument and then the set of the special brushes, right? Now when we use computer technology, sometimes enough to take vaginal discharge, but always has some cells, always. It's actually created with cells, not just like, you know, a liquid part of discharge. And that's why the more potential this method, like, you know, high quality masses, they have better ability to find even little changes. So we were going like in technology way. So we improve technology, and probably one day we will be doing this test at home. So we'll be like, we have this blood test for like stool, like blood in stool test. Like, remember, now they send home. So you do
Right.
it at home, and then you send it back to the lab. You don't need to go anywhere, and you have your private intimacy in your washroom, and then do
Right.
whatever you want, right? So
Right.
the same we try to do with this test. So maybe in a couple of years, you don't need to go to a doctor. You can be tested at home. You just order the test, and then you do it and send to the lab. And I think it's wonderful, because since this way, probably more women could test more often. not every day, but
Even the busy women, as you said, as the demographic,
Yes.
the research is indicating that women who are a bit older than this 18 to 25 are the ones who are going to be the most risk at having cancer, but they're in a busy period of their life with kids
Yes.
and working. But if they can do this at home.
yes, and I think it's wonderful because I myself, I like a comfort. I don't want to go to doctors many times, right? So if I get this test, if I get something
right.
like that, it would be for me much more easy. And then again,
Right. It's much
if
more
I do
convenient.
something wrong, it would be my responsibility. Again, I'm not going to blame doctor, but that's why I try to do everything properly. I read instruction, not just like knowing how to do everything, right? But I will be reading instruction before the steps. And instruction, by the way, created in an easy way, that even with pictures, that you just, even if you don't know English perfectly, but again, not even about English. Now you can order in many languages now, but then it has pictures how to do it, which is wonderful.
It is.
So probably you shouldn't worry. Maybe in a couple of years you will have this test all around, or at least they will be provided by doctors or some clinics or some organization, I don't know. And we'll have a lot of changes even in the screening program. That, but definitely, I want to say very important words that 99.9% of women would never have cervical cancer.
Okay.
Okay, because when we look through the statistic, it's a rare disease, even if we hear about it, it's a rare disease. So that's why not every 10th woman, not every, it's a lie. It's mostly created by some kind of advertisement or whatever, but it's a rare disease. So, and plus, because it's not rapid growing cancer, you will have time to follow yourself, like, you know, to follow up yourself. You will have time to find out if you have any changes or not, if you're interested in your health. This is probably the most important message, that don't rush. I usually, my favorite expression in Latin, festina lenta. It means, you know,
slowly.
be in a hurry, but slowly. It means not in a hurry, but it means move, but enjoy life around.
That's right. That's right. Thank you so much. I'm going to stop recording now. I really appreciate your time on behalf of our young women as well. And thank you again, Dr. O.